Good afternoon, everyone, and welcome to the IFSO APC webinar on obesity and cancer. This session aims to explore the association between obesity and cancer to examine the role of metabolic and bariatric surgery in altering the cancer risk. I'm honored to be chairing today's webinar. My name is Mohammad Kerman Sarawi. I'm Associate Professor of Surgery and MIS Metabolic Bariatric Surgery Fellowship Course, Co-Director at Iran University of Medical Sciences in Tehran, Iran. I'm also serve as the chair of the IFSO APC Scientific Committee. To begin the discussion about the link of obesity and cancer, we will hear from Professor Samantha Hacking. She is an associate professor of endocrinology at Royal Prince Alfred Hospital and the clinical academic member at the University of Sydney. She served on the Council of the Australian and New Zealand Obesity Society and is the current president of National Association of the Clinical Obesity Service. Her research focused on the metabolic complications of obesity, and she is deeply committed to enhancing the quality of obesity care in Australia. In addition to her academic work, she treats the patients at the Metabolism and Obesity Service at Royal Prince Alfred Hospital. The second speaker will be the Professor Wendy Brown, who will present on the topic, does MBS change cancer risk and who needs ongoing surveillance? Professor Brown specialized in esophagogastric cancer, gastroesophageal reflux disease, and bariatric surgery. Her research interests include the health benefits of weight loss, the physiology of upper GI procedures, service delivery models in bariatric surgery, and registry science. She works closely with basic scientists studying mechanism of satiety, non-alcoholic steatohepatitis, and esophageal cancer. Professor Brown is the program director of surgical service and professor and chair of the Department of Surgery and Monash University at Alfred House in Melbourne. She also is the clinical director of the ANS Bariatric Surgery Registry, chair of the Victorian Preoperative Consultative Council Surgical Subcommittee, and has held numerous leadership positions, including past president of OSANS and ANSCOSA. Following these presentations, we will engage in a panel discussion with our distinguished experts, Professor Chetan Parmar, Professor of Surgery at the University College of London, Consultant Bariatric Surgeon, Director of Surgery and Cancer, Educational Lead, and Council Member of the British Obesity and Metabolic Surgery Society, and the member of the IFSO Executive Board. And then Professor Takeshi Naito, the leading expert in colorectal cancer and bariatric metabolic surgery in Japan. Professor Naito is the president of the Japan Society of Laparoscopic Colorectal Surgery and the board member of both the Japan Society of Endoscopic Surgery and Japanese Society for Treatment of Obesity. We encourage all attendees to submit their questions using Q&A chat box. Please note that this webinar is being recorded and will be made available through the IFSO Virtual Academy on the IFSO website and YouTube channel. As the first speaker, I invited Professor Samantha to start her lecture. Samantha, please.
My name is Sam Hocking and I am a clinical academic endocrinologist at the University of Sydney and Royal Prince Alfred Hospital in Australia and the current president of the National Association of Clinical Obesity Services. These are my disclosures, and relevant to this presentation, I have worked with a number of the companies that make anti-obesity medications that are available in Australia. So we're here to talk about obesity and cancer, the link between obesity and cancer, and whether weight loss may help patients reduce the risk of malignancy. We know that obesity is associated with 13 cancers, and these are now recognised as obesity-associated cancers or malignancy. Obesity-associated cancers account for approximately 40% of cancer diagnoses in the United States. As we know, the incidence of obesity is rising, and concomitant with that, the incidence of obesity-associated cancer is also rising. And it is predicted that obesity will surpass tobacco use as the number one preventable cause of cancer in the near future. We also know that not only is there an association between the presence of obesity and the risk of cancer, but that the risk of malignancy actually increases as an individual's body weight increases. And shown here is a gender-specific summary of the increasing risk of cancer with each 5 kilogram per metre squared increase BMI. And shown in this umbrella review are the obesity-associated cancers, or those malignancies that are known to have a relationship with obesity. And we can see that the risk increase varies quite a lot. So, for example, there's a 9% increased risk for rectal cancer in men, but the association is much stronger for something like esophageal adenocarcinoma, where the increased risk is about 51 to 52% in men and women. Now, there have been numerous mechanisms proposed linking this association between obesity and cancer risk. We're all very familiar that obesity is a state of pro-inflammation. This is resulting from expanded adipose tissue, there's adipose tissue hypoxia, there's recruitment of inflammatory cells, there's recruitment of new vascular tissue. So we're very aware of the pro-inflammatory nature of excess adiposity, and that this results in systemic inflammation, and this can unfortunately drive mitogenesis. We're also aware of hormonal disturbances that are associated with the state of having obesity, and this is particularly well known with the association with postmenopausal breast cancer, where peripherally in adipose tissue, androgens are converted to estrogens, which then can drive some of these estrogen-dependent malignancies. Another one to think about there is endometrial carcinoma. We're also aware that there is a disruption of the gut microbiome, and this may have an association with colorectal cancers. There's dysregulation of adipokines, and there's also the physical components of obesity that can drive an increased risk for malignancy. And one of the associated cancers we can think about here is esophageal adenocarcinoma, which can be associated with reflux resulting from increased intra-abdominal pressure as a result of visceral adiposity. We've also become more aware of the link between obesity and reduced immunity. And this really did come to attention, I think, during the COVID-19 pandemic, when we saw that increased risk around COVID-19 infection and poor outcomes in people living with obesity. And we also, I think, increased our knowledge regarding the reduction in vaccine response that is seen in people with obesity. And similarly, obesity reduces anti-tumor immunity and therefore allows tumor cells to more rapidly proliferate. So this not only has an impact in terms of cancer development, but also there's an increased risk of spread and metastatic disease in people who are living with obesity. Shown here on this graphic, and it's possibly a bit too technical for this webinar, are some of these mechanisms that include T-cell exhaustion, T-cell inactivation. There's competition between the cancer cells and the local adipocytes in terms of fuel, and if the adipose tissue associated with the cancer is more lipolytic. It actually fuels the growth of the tumour cells, and there's also a reduction in natural immunity with an ineffective natural killer cells associated with the tumour microenvironment. Now, all of these underlying mechanisms do contribute to this increased risk of malignancy, but of course not all malignancies are the same, and not all of the risk factors contribute equally. And I think I've kind of hinted at this a little bit already. So if we think about a couple of different obesity-associated cancers, liver cancer, colorectal and endometrial cancers, the drivers are slightly different. The pro-inflammatory state tends to be pretty uniform across the board in terms of increasing the risk of malignancy. As I mentioned, there's the disruption of the microbiome, particularly for colorectal cancer. Interestingly, this peripheral conversion of androgens to estrogens, which drives things like endometrial cancer, oddly can actually be protective in some malignancies, such as colorectal cancer. So not all the mechanisms are similar, not all the mechanisms contribute to all the types of cancer, but in general, there is this increased association between obesity and malignancy, particularly for those 13 cancers that I've already shown you so far. Now, another way to think about the association between obesity and cancer is not only obesity as a risk factor for cancer, but also obesity as a barrier to accessing cancer screening. Now, if we think about, at least in the Australian context, the cancers that we routinely screen for, this includes breast, cervical, bowel cancer, and prostate cancer in men. Now, the way that we screen for these cancers can be quite embarrassing and confronting to someone who is living in a larger body. And this systematic review of obesity as a barrier to accessing cancer screening service identified a number of issues that specifically relate to the population living with obesity, where cancer screening is a barrier. And you can see things such as embarrassment and modesty, reluctance to get undressed and to show your body, equipment not being sufficient for someone who is having a higher BMI, and the unfortunate experience of stigma or fat shaming when patients have accessed health before. There may also be fear not only of getting cancer, but self-blame that it's your own fault, that you're at risk of cancer. And then there may also be a fear of how you'll be able to be treated for that cancer when you are living in a larger body. If we take an example of cervical cancer screening, we know that women with obesity are unfortunately less likely to go ahead to be screened, so they have a reduced odds of actually attending a screening appointment. And then unfortunately, if they do go on to have a pap smear performed, they've got a much higher rate of having an unsatisfactory cervical smear, so that the screening process was unsatisfactory and needs to be repeated. There's also, unfortunately, an impact of obesity on response to cancer treatment. So unfortunately, there's barriers at all levels. So if we even start thinking about the very beginning, where someone might need to have, say, a breast lump removed or surgery performed, we know that obesity does increase the risk for post-operative complications, for infection, for bleeding, for poor wound healing, an increased risk of deep vein thrombosis. There may be increased risks of lymphedema after lymph node dissection. There's also issues around the prescription and dosing of chemotherapy in patients who have a high BMI. So do we dose based on body weight, on body surface area, on adjusted lean mass? What's the correct dose of chemotherapy to deliver? And there can also be technical difficulties around delivering radiotherapy, not only to do with the setup and the equipment, but also that the tumour location may have more freedom of movement in someone who has a larger body. So shown here is a graphical example of breast cancer as an example of how obesity can have an impact on the delivery of therapy. So as mentioned, there can be increased risk of surgical complications, there can be resistance to radiotherapy, there can be a reduction in the efficacy of chemotherapy and endocrine therapies, and also that weakened anti-tumour immune response can impact immunotherapies. And this all then leads to a reduction in the efficacy of treatment of breast cancer in women who have concomitant obesity. Unfortunately, the presence of obesity has also been shown to increase both all-cause and cancer mortality. So shown here in the red boxes are those patients who experienced an increase in overall mortality, and you can see there was an association between the presence of obesity and overall mortality in breast cancer, colorectal cancer, and endometrial cancer. And then in terms of the cancer-specific mortality, there was an association with breast cancer, colorectal cancer, pancreas cancer, and prostate cancer. And this is true if we look at the increased risk of cancer mortality across both genders. So there is an increased risk of overall cancer mortality from all cancers in men. And you can see that relative risk of death being 1.52 for all cancers in men. And in terms of an increased relative risk of death of all cancers in women being 1.88. In terms of those cancers which have the highest risk of mortality in men, that's liver with a 4.52 relative risk of death compared to population with a normal body weight. And then in women for uterine cancer, an increased risk of 6.25 compared to those who have a normal body mass index. So the next really important question is, well, does reducing weight reduce cancer risk? And I'm sure Wendy is going to be talking a lot more about this when it comes to metabolic bariatric surgery. So what do we know about from medical weight loss studies? So this is an analysis of the Look Ahead trial. So for those of you who aren't familiar with this study, this was an NIH-funded trial. It was in a population with type 2 diabetes. It was an intensive lifestyle intervention with the ILI and the blue lines here compared to usual therapy, standard therapy, which is the DSE line or the red line in this analysis. So the main point of the Look Ahead trial was whether an intensive lifestyle intervention in patients with type 2 diabetes could actually reduce the risk of cardiovascular outcomes. But because it was a long study done in a large number of people, other sub-analyses have been able to be performed. And this one looked at whether or not an intensive lifestyle intervention in a population with overweight, obesity, and type 2 diabetes could reduce the risk of cancer. So shown in panel A is the risk of all cancers. And you can see that the confidence intervals here overlap, and there was no effect of intensive lifestyle intervention, including weight loss, on the reduction of incidence of all cancers. However, if we look at panel B, which was the cumulative incidence of obesity-associated cancers, so those 13 known obesity-associated cancers, you can see that these lines did show more divergence. Unfortunately, the confidence interval still did cross 1. The relative risk reduction was about 16%, but the confidence interval went from 0.68 to 1.04, showing that probably this was underpowered to show that losing weight did reduce the risk of obesity-associated cancer. In terms of an impact of this intensive lifestyle therapy on the probability of cancer mortality, again, there was no effect. So that's not strong evidence, it's not definitive evidence, but it does suggest that in a bigger powered study that losing weight may actually be protective against the development of these obesity-associated cancers. So one of the issues, of course, with a lifestyle intervention is that the weight loss is relatively modest. So you can see that over the first year of the Look Ahead trial, there was quite a significant reduction in weight, and that was about 8 kilograms. But unfortunately, as time went on, the difference between the control and intervention group waned. And so there was only about a 2.5 kilogram difference between these groups over time. So this may not only be a result of being underpowered, but that the weight loss was not enough to show an impact on cancer mortality and incidence. So looking at this in another way, with another study, this study then looked to see whether there was an association with the magnitude of weight reduction and decreasing cancer risk. And you can see from this analysis that there was a very small effect with a weight loss of more than 5 kilograms, and that was reducing the risk of cancer. But for those who didn't lose very much weight, only a change of 2 kilograms, there really wasn't an impact at all. And so there does appear to be a relationship between the magnitude of weight loss and the ability to reduce the risk of overall cancer. So another question then is, could GLP-1 receptor agonists lower obesity-associated cancer risk? And again, this study has been done in type 2 diabetes because this is where we have the larger number of patients who have been on these medications for a longer amount of time to be able to perform a pooled analysis such as this one. So in this particular study, they looked at patients with type 2 diabetes who were prescribed GLP-1 receptor agonists and compared those who were on GLP-1 receptor agonists but not prescribed insulin to those who were not prescribed a GLP-1 receptor agonist but were prescribed insulin. And what was seen overall is that, yes, the use of the GLP-1 receptor agonist did appear to reduce the risk of obesity-associated cancer, particularly when compared to insulin. Interestingly, they did another analysis comparing those receiving GLP-1 receptor agonists to those receiving metformin, and there was no significant difference when that comparison was made, but there was a reduction in the risk of obesity-associated cancer comparing GLP-1 and insulin. And shown here is an example of one of those obesity-associated cancers, this time showing you the incidence of colorectal cancer. And you can see this quite lovely divergence of the curves separating early in terms of time. Obviously, as time goes on and the numbers get smaller, the confidence intervals get broader, but you can see that there does appear to be a protective effect of GLP-1 receptor agonists lowering the risk of colorectal cancer in patients with type 2 diabetes. So, of course, one of the more effective therapies in terms of the magnitude of weight loss is bariatric surgery. And I've only got one slide on this because I know that this is a topic that Wendy is going to be covering, but this shows the reduction in obesity-associated cancers in a population who underwent bariatric surgery, in this case sleeve gastrectomy or bypass, compared to non-surgical controls. Quite a large effect size there, with a reduction in risk of 32% for obesity-associated cancer. And there's also a reduction of 17% for total cancer cases, and then a really large reduction in cancer-related mortality with a hazard ratio there of 0.52 in favour of bariatric surgery. So I guess another thing to think about is, what about somebody who has already received a diagnosis of cancer but is also living with obesity? Should we be focusing on weight-reducing therapies in this context? Obviously, knowing that if you develop sarcopenia and frailty in the setting of cancer, prognostically that is detrimental for outcomes. So should we be thinking about medical nutrition therapy for obesity in someone who has obesity and cancer? So the recommended nutritional strategies that came from this consensus were that possible options to follow would be the Mediterranean diet. We know that's very anti-inflammatory, and with that pro-inflammatory association between obesity and cancer risk, that makes sense that you might choose an anti-inflammatory diet. They also mentioned a potential use of a ketogenic diet, and one of the reasons for this is that it can lower insulin levels and glucose availability, which could help drive the growth of malignant tissue, and that there may also potentially be a role for intermittent fasting. And again, this has to do with sort of lipid and glucose metabolism. But the overwhelming comment to make here is that the evidence for supporting any of these strategies is very limited. I guess moving on then again, what about someone who's survived cancer but has developed obesity, which can happen in response to some cancer therapies, or had obesity and survived cancer? Should we be thinking about using anti-obesity medications or behavioural interventions in these patients? And the advice here was basically, if the person's indicated for a therapy because of another reason, such as having type 2 diabetes, then it would certainly be appropriate to use GLP receptor agonists. And in people who have high body weight or obesity with comorbidities, then indeed treating the obesity on the merits of the obesity itself with rate reduction through bariatric surgery or medication would be appropriate. So I think in summary, what this presentation shows is that obesity actually affects every aspect of the cancer continuum. So I've shown you data showing that obesity increases the risk of 13 obesity-associated cancers, that obesity itself is a barrier to cancer screening and the early detection and diagnosis of cancer, that obesity unfortunately can interfere with the therapy for cancer, and that in cancer survivors, there may be an increased risk of cancer recurrence. There is an association between increased cancer mortality and obesity. But in those who are survivors of cancer and who have obesity with complications, we still do need to consider therapy for the obesity on its own merits. And with that, I'll stop, and I'm happy to take questions and then to pass on to Wendy. Thank you.
Good evening. Thank you very much for giving me the opportunity to present today. My name is Wendy Brown and I'm a surgeon in Melbourne, Australia. This topic today supports two of my great clinical interests, being cancer surgery as well as metabolic bariatric surgery, and it's a real privilege to have the opportunity to talk about this with you. I'll firstly cover off today what impact metabolic bariatric surgery has on cancer risk. We'll move then to focus more on esophagogastric cancer, given the particular impact that these surgeries have on those cancers. And we'll talk briefly at the end about what surveillance might be needed into the long term for our patients for their ongoing cancer risk. These are my disclosures. We all know that there is an association between overweight, obesity and cancer, and the CDC in the USA now clearly documents that there's at least 13 cancers where there's a very strong linkage. And this is important because it's now estimated that 40% of cancers diagnosed in the United States each year are related to overweight or obesity. And this is reflected in both the incidence of cancer, with a very high increase in the incidence of cancer risk for each 5 kilograms per metre squared increased in BMI, as well as risk of cancer mortality. So cancer mortality and cancer incidence is both impacted by overweight, obesity, and this is creating a significant disease burden in our communities. So how can we help people? Well, we all know that metabolic bariatric surgery produces significant and substantial weight loss that is durable into the long term, and that translates to a large number of health and well-being benefits for our patients. This then ultimately means that people who undergo metabolic bariatric surgery are at lower risk of dying when compared to people living with obesity who have not undergone a metabolic bariatric surgical treatment. This also applies to cancer, and some of the strongest evidence we've seen is in the prospective cohort study coming out of Sweden called the Swedish Obese Subject Study. In this study, which started in the 1980s, where they compared a group of people who underwent a metabolic bariatric procedure including vertical banded gastroplasty, fixed adjustable gastric bands and Roux-en-Y gastric bypass, with a cohort of people living with obesity who did not undertake a surgical treatment. They've been able to show that over a 20-year period there is a reduction both in the incidence of cancers and also a reduction in cancer-related mortality. This graph here shows the unadjusted cumulative fatal plus non-fatal cancer incidence from the start of the intervention by sex. And you'll see that the benefit is strongest for women when compared to men. And the cancers where we see the biggest benefit tend to be ones that are possibly more sex-related, but are definitely more linked to obesity than not related to obesity. And the magnitude of benefit that's seen was similar for both the fixed gastric banding, the vertical banded gastroplasty. Interestingly, the Roux-en-Y gastric bypass didn't have a significant effect, but I think that's just a sample size error, as there was only 189 people in this cohort study who had undergone Roux-en-Y. So this is really important prospective data showing in the real world that people who undergo a metabolic bariatric procedure have a significant improvement in their overall cancer risk, but the effect size was definitely bigger for women than for men. There's also been a large number, a few now, very large retrospective series that confirm that in people who undergo a metabolic bariatric procedure, there's a reduction in risk for people who undergo a bariatric procedure. So in this study, this is the Kaplan-Meier estimated cancer-free survival for all cancers, and you'll see survival is improved in the group that underwent metabolic bariatric surgery. And that's for all cancers, for obesity-related cancers, and also in cancers not associated with obesity. And again, the effect size, particularly for the incidence of cancers, is strongest seen in females rather than men. In another very large retrospective study coming out of Cleveland, they were also able to demonstrate that metabolic bariatric surgery was significantly associated with a lower risk of obesity-associated cancer, as well as cancer-related mortality. And importantly, they showed that this effect was similar regardless if you had a sleeve gastrectomy or a Roux-en-Y gastric bypass. Another very large study coming out of the USA, out of Utah, is important because it's now been studied out to 38 years. In this group, they've studied 22,000 metabolic bariatric surgical patients, representing the 4 major types of bariatric surgery that have been performed over that period, and they demonstrated a 25% reduction in cancer incidence in the surgical group compared to the non-surgical group, with a 41% reduction in cancer incidence for obesity-related cancers in female patients. Importantly, this also translated to a 43% lower mortality for cancer. So there's very strong evidence demonstrating that metabolic bariatric surgery does help to reduce the risk of cancer incidence and also cancer mortality. But there are some caveats to this in that it tends to be really the females that are seeing the strongest effect size, and the effect size is more in those obesity related cancers, although there is some benefit in the non-obesity related cancers. But there is heterogeneity, and this is a table summarising some of the other studies that have come out, including some smaller studies. And one area of particular controversy is colorectal cancer, with some studies producing a risk reduction, but other studies suggesting a risk increase, particularly for bypass patients. And so I think it's an area that we're still learning about, but the signals are that there's definitely seems to be a benefit for metabolic bariatric surgery in reducing that cancer risk. So why is it that metabolic bariatric surgery reduces the risk of cancer? We don't really know, and it's likely it's not just weight loss, because if we again drill down in the Swedish obese subject study, we can show, looking at the female cancer incidences, it didn't really matter how much weight you lost. It was the fact that you lost weight that was important. So losing more weight didn't seem to reduce your weight anymore. And it didn't matter which type of treatment if you had, and if you combine that with the weight change, those two things combined didn't make a difference. There was a difference according to how old you were. You're more likely to get a cancer when you're older. If you're a smoker, you're more likely to get a cancer. And if you carry your weight around the middle, then you are more likely to get a cancer in females. I found that a bit interesting because men typically are more likely to carry their weight around the middle, yet we don't see the same effect size in men. So I think there's a lot we don't know. And there's lots of things that people are thinking about. Could there be an effect with metabolic bariatric surgery on the rate of cell proliferation? Could it reduce oxidative stress? Is the impact on insulin resistance important? Maybe it's to do with adipokines or the gut microbiome. Given that the effect size is seen more in women, possibly it's to do with the ER and PR receptors, or it could be to do with bile acid concentration, particularly thinking about that potential increase in colorectal cancer risk in bypass patients. And I think the simple answer is we don't know, but it's an area for rich research, and I think it's something, real opportunity, I guess, for us to learn a lot more about genomics and about cancer, as well as metabolic bariatric surgery, if we focus on this. Drilling down now on esophagogastric cancer and metabolic bariatric surgery, I think this is something that we have all been thinking a lot about, because we know that people who are living with obesity, so people in higher BMI categories, are more prone to esophageal cancer, particularly adenocarcinoma, and that's true in both women and men. And adenocarcinoma of the esophagus follows a very predictable pathway. It starts as reflux changes, it goes to Barrett's esophagus, it goes to Barrett's then with dysplasia, both low grade and high grade, and ultimately ends up as an adenocarcinoma. And the thing that causes all of this is reflux. And we are often performing operations that are refluxogenic, particularly sleeve gastrectomy. So it's an area that I think we need to think about, because we're taking people who are already at high risk of esophagogastric cancers, and we're subjecting them to a procedure that may end up increasing their risk because it increases the risk of GERD. In addition, when we know historically when we join the stomach to the bowel, there's an increased risk of stomal cancers. And so there's a very real risk that some of the procedures that we do, such as bypass procedures, may increase the risk also of stomach cancers. And certainly there was some very early signals suggesting that this may be the case following metabolic bariatric surgery, and some early work, particularly out of Austria, back in around 2018, suggested that it was a 15% de novo incidence of de novo Barrett's esophagus at 10 years in people who underwent a sleeve gastrectomy. This was very concerning because it made us think, gosh, are we going to see a tsunami wave of adenocarcinomas of the lower esophagus in the years to come? The IFSO addressed this in a position statement in 2020, recognising that we do surgeries that increase the risk of GERD, and we are operating on people who are already at increased risk of people with living with obesity, so at an increased risk of adenocarcinoma of the lower esophagus, and also that we do operations that in theory could lead to the increased risk of stomal cancer. So the IFSO at that stage had a position statement suggesting that there should be a routine gastroscopy or EGD performed in populations where there was an insignificant risk of gastroesophageal pathology, and especially if some of the stomach was going to be inaccessible. And that's particularly important in Asia, where there's already also an increased background risk of gastric cancers. Similarly, because of that increased risk of Barrett's, there was a real fear that we might miss something if we didn't routinely survey people. So at this stage, there was a suggestion that we should do every 2 to 3 years a gastroscopy, particularly for people who'd undergone a sleeve gastrectomy or a one anastomosis bypass because of bile reflux, so that we could survey the area. And that was consistent at the time with the regimes that were suggested for those people at high risk of cancers or Barrett's esophagus with dysplasia. And it was recognised this was a conservative approach, but it was considered safe. Since that time, though, there's been a lot of updating to the local guidelines for Barrett's esophagus screening, and now for non-dysplastic Barrett's, there's some guidelines suggesting every 3 to 5 years. There's some saying you don't need to do it unless it's longer Barrett's, and there's some that say, you know, you don't really need to think about it too much at all, especially if it's an irregular Z-line, which is possibly what was being confused for when those early gastroscopies were performed in Austria. And there's been a number of studies now suggesting that the background rate of Barrett's esophagus is actually much lower. So the current guidelines have changed, and so maybe it needs to be considered that we need to also think about it from an IFSO position statement point of view. In addition, there's a lot of evidence now coming, there's some more evidence coming through suggesting that the risk of esophagogastric cancer after metabolic bariatric surgery is not as high as we might have thought. And this is a very large study that came out of France, looking at over 300,000 patients, and it showed a significant reduction of esophageal and gastric cancers. And again, it was regardless of which procedure you performed, be it a sleeve gastrectomy, a gastric band or control. I think a little bit worryingly, when you look at it later years, potentially there is a bit of a flag that maybe sleeve still needs to be looked at, but the numbers are fairly small out there. But it's certainly not a significantly increased risk. It's probably very similar to the background risk of the population. Similarly, when we go back to the Barrett's esophagus stage, we can see that when we look at all, this is an updated systematic review performed by Oliver Fisher just recently, you can see that the post-operative incidence of Barrett's esophagus is actually not much higher than the background population now, looking at a large number of studies. And particularly looking at sleeve gastrectomy, you can also see that that background risk of Barrett's esophagus is actually now thought to be approaching the general population risk. So the original study by Falconrich in 2018, as well as Sebastianelli, probably skewed our early thinking because they suggested much higher rates of Barrett's after sleeve gastrectomy, whereas more modern papers, I guess, are suggesting much lower rates. And that's similar with OAGBs, not suggesting an increased risk of Barrett's or stomal ulceration. So I think since the last position statement in 2020, we've had some reassuring data that suggests that the background risk of Barrett's esophagus for both sleeve gastrectomy and OAGB, as well as stomal cancers for OAGB, is actually probably very much the same as the general population. And reassuringly also from France, the translation to the stage of esophageal or adenocarcinoma of the esophageal or gastric adenocarcinoma is also very similar to the background population and may actually be a little reduced when compared to the background population. In addition, when you think about the recommendation that you consider a preoperative gastroscopy on everyone, I think we can still see, and again this is an updated review of the literature performed by Yasmin Jahari, you can see that there is some benefit because we do find abnormal endoscopy findings that require medical management about a third of the time, an abnormal endoscopy finding leading to delays or changes to metabolic bariatric surgery about a quarter of the time, but contraindications are fortunately rare, less than 1% of the time. So roughly 70% of the time we are seeing that this preoperative EGD or gastroscopy does make a difference, but fewer than 60% of practitioners are actually following the guidelines at the moment. Therefore, that makes us think, is this something that's useful? So the IFSO is currently going through a procedure at the moment to review the position statement on Barrett's esophagus as well as on EGD, and I think hopefully soon we'll be able to use these new data, which are not yet published but will be published very soon, and I think we will consider the updated professional society guidelines, and I think the position statement will reflect our current understanding of these diseases as well as what the updated guidelines for screening and surveillance of Barrett's esophagus and adenocarcinoma of the stomach and esophagus are. So given that there is a risk reduction for people who undergo metabolic bariatric surgery, how should they be surveyed for cancer? Well, whilst there is a risk reduction, people don't have a zero risk of cancer. Their risk of cancer is reduced, but it probably goes back towards the general population risk, and it may still be above the general population risk because if you look at the Swedish obese subject study again, whilst there's a reduction in overall mortality in people who undergo surgery, being this orange line, when compared to people who don't undergo who are obese, living with obesity and don't undergo metabolic bariatric surgery, so people who undergo metabolic bariatric surgery have a reduced overall mortality, it never approaches the level of people who've never lived with obesity. So I think it'll be something similar with cancer. I don't have the data to confirm that, but I think that we still have to consider people who are living with obesity and have had a metabolic bariatric procedure at least the general population risk of cancer, if not just slightly higher. So I think it's important that they still follow the local guidelines for all their cancer screening and surveillance. And it's really important that we adopt a personalised medicine approach and really listen to our patients and take the time to understand what's important to them, but also make sure that they're hooked into a really good healthcare team that makes sure they get that holistic care that they need. So in conclusion today, I'd like to just thank the organisers again for the opportunity to speak to you. I think we need to recognise that people living with obesity have an increased risk of at least 13 cancers, and that's at least 40% of the population in the USA and probably very similar around the world. Metabolic bariatric surgery does reduce the risk of developing a cancer and of cancer-related mortality, but this effect is stronger in women than men, and it doesn't seem to be procedure dependent, nor does it seem to be the extent of weight loss dependent. So whether or not there's a threshold of weight loss that's important, or if there's other mechanisms at play, I don't think we know. There is still a risk of cancer in people who have had a bariatric procedure, and people still need to be screened and surveyed after metabolic bariatric surgery according to their local guidelines and their individual risks. This is just some acknowledgements of people I work closely with, and again,
Okay, thank you, Samantha and Wendy, for your excellent and very impressive presentation. Let's move on the panel discussion. We will also answer the questions submitted by the audience through the Q&A box. And we have less than 15 minutes to discuss about these lectures. As the first question, I ask the panelists, Professor Jacques Himpans asked that with the significant increase in obesity cases prevalence in the recent years, is there any parallel increase in cancer cases, and as could be expected? Chiton, please.
Thank you very much, Mohammed. First of all, for the kind invitation to join you as a panel here. And thank you again, Samantha and Wendy, for this excellent and interesting talk. I don't know what my viewers have learned, but I'm learning a lot already. Thank you. And now coming to Professor Himpan's question, I think an interesting question, and it does seem the obvious answer should be yes. I think we should be seeing increased rate in cancer cases with the increase in obesity globally. So that would be my brief answer.
Takeshi, what's your opinion?
Well, yeah, actually, the cancer cases associated with obesity is definitely increased, but I don't know whether it is a parallel to the body weight increasing, because that cancer generation, tumor generation is affected by the many factors. So the obesity is one of the factors for the tumor generation. So I don't know whether it is a parallel.
Okay. My question is, do you think that metabolic and bariatric surgery can reduce the risk of cancer recurrence in treated patients or not? Wendy, please.
I don't. It depends which cancer it is. If it's an obesity-related cancer, then possibly. But I don't think it reduces the risk to zero. And it doesn't change the fact that the person has previously lived with obesity, and probably even after a metabolic bariatric procedure is still living with a degree of obesity, because it's very rare that we bring people right back down to a very normal or a BMI that's in that sort of 20 to 25 range. So I think it should have some benefit. I don't think we've got the evidence to prove that, and I think you should still treat your patient as you would according to sort of normal protocols, surveying them after they've had their treatment, because at the moment I don't think we can say that weight loss is enough.
Thank you. Samantha, what is your opinion?
Look, I agree with what Wendy said, and I think it's wonderful if somebody's weight comes down enough that they then start participating in the routine screening that we have for a number of the obesity-associated cancers, well, particularly breast cancer in women would be one of those examples. Colorectal cancer, I guess, is another example. And given that participation rates are quite low in people who are living with higher body mass indexes, if those body mass indexes come down, or admittedly they may be lower, but not completely back to normal, they may still be in the range where they have obesity or overweight. But if we can get people still undergoing routine screening, then that's an advantage.
Thank you. Another question is what kind of procedures can exactly decrease the risk of cancer development? For example, such procedures such as OAGB or Roux-en-Y gastric bypass that has a gastric remnant that is inaccessible to endoscopic follow-up maybe have a more risk for gastric pathology development than other resectional procedures, such as sleeve gastrectomy or SADS. Chetan, what's your opinion?
Thank you. That's an interesting question, Mohammed. And I think Wendy touched on this topic at the end of her presentation. I think she mentioned that the recent evidence, or whatever evidence we have, we are still learning. And I think she was clear that at the moment we can't say, or the evidence doesn't show one procedure reduces the cancer risk compared to the other, which is in a way interesting because theoretically you would think procedures like, say, a gastric band or a sleeve, which are refluxogenic and so would probably not necessarily reduce, but probably also increase a chance of reflux and its long-term consequences. And again, I think Wendy touched very nicely on that gap in knowledge. So personally, I don't think at the moment you can swear by anything that one procedure is better than the other for that, and probably time will tell. And on mainly, I think long-term registries is what the answer should be. Not just about bariatric surgery, but we need to also capture this cancer data. And I think only then, in another 10, 20 years, we'll be able to give this answer, because these are long-term results, not just 1 or 2 year follow-ups. And that's what, as a society and as a international society, we should be addressing. Thank you.
Thank you. Takeshi, what's your opinion?
Yeah, same with the Chetan, and then Wendy told that in her presentation, and we will see. We don't know yet.
Okay, another question is there any data of safety of bariatric surgery as a part of the treatment for the patients diagnosed with cancer and obesity? What's your opinion?
Who, me? Takeshi?
Takeshi, please.
Sorry, I don't know that we have any data about, I presume they're asking about concomitant treatment, that someone who's diagnosed with cancer, do we offer them metabolic bariatric surgery? Obviously if someone's in a palliative setting, you wouldn't want to do that. I think that, that would not be appropriate. But if someone has a treated cancer, then there's no problem with treating someone with metabolic bariatric surgery. But again, I think it comes down to it's very hard to generalize. Cancer is a very broad term that covers a large number of conditions, and, hematopoietic cancers are going to be different to endometrial cancers, which are going to be different to GI cancers. So I think it's something that you just need to think about very carefully and work through the potentials with your patients.
Well, actually, can I talk?
Yeah, please.
Well, I have one case, is the case with the rectal cancer whose BMI is over 60, and it's a very advanced case, and we cannot do the rectal cancer surgery with the BMI over 60. So we did the chemoradiation therapy. We can get around 3 months or 4 months to the radical surgery, and between that we did the sleeve gastrectomy to reduce their body weight. And it's a kind of a bridge bariatric surgery to the malignancy. We should focus on that such kind of cases in the future.
Is there a
Definitely.
problem with chemotherapy and healing? You know, if you
No.
did you have to
To reduce the size of the tumor or to prevent the local recurrence, we always do the chemoradiation therapy for the rectal cancer, advanced rectal cancer, locally advanced.
Can I make a comment here?
Yeah.
I think this is where, the future, like what is the role of bariatric surgery as a bridging for patients with diagnosed cancer. We did, interestingly, collect the global data on that. We published a series of 37 patients, and I think that is the only published series. And this is probably relevant to this question, and exactly what Takashi mentioned, that patient is diagnosed with cancer, but then is high BMI. Say uterine cancer with a BMI 60, it is difficult to do a hysterectomy, or a prostate cancer who needs a prostatectomy but a BMI 65. And in those ones, those are the low grade, less aggressive cancers where you could probably buy some time safely. And I think in an MDT setting, you can say, okay, let's do a definitive bariatric surgery on them. They lose weight, they go on an expedited pathway, and then they can have a definitive cancer surgery. I have put the citation of that paper because that's, I think, the only paper at the moment globally into that answer, if anybody wants to look at it. But I think that's something worth exploring more. But again, I think it would be more so related to those hormonals and what organs you would do that for. Interestingly, in that study, we found 9 different organs. I expected more of uterines and prostates and breast cancer, but we had some odd cancers here and there as well, which was interesting.
But I think GLP-1s, and Samantha might want to comment on this, might change, the immediacy of a GLP-1 and the safety may be attractive in that setting. I don't know, Samantha, if you have any experience in that, or the injectables.
Yeah, sure. I don't have any personal experience of using the GLP-1s in the setting of, reducing body weight in a patient with malignancy. But I think just like you could potentially look at bariatric surgery as a potential treatment, you could look at using an incretin-based therapy to reduce weight. And I think this is really one of these areas where we've got to think very carefully about a person's body composition. I mean, we all know that BMI doesn't necessarily reflect whether somebody's got sarcopenic obesity or what's going on there. And certainly sarcopenia and frailty in cancer is something that's associated with a poorer prognosis. I guess one of the advantages of using something like a GLP-1 receptor agonist is that it is reversible, so that once the person loses enough weight to then have their cancer therapy, you can remove the GLP-1 and then remove any of the effects on appetite, food intake, macronutrient composition, and then the person is back to where they were before. There is a risk of weight regain, obviously, in that setting, but then if they're really struggling with nutrition as a result of their cancer therapy, at least you're not having something that's an irreversible bariatric procedure like a sleeve gastrectomy, where they're always going to then have that risk of low nutrition. So I think there's not a lot of evidence to base any of these comments on. It's all my personal opinion. But I think, these are very difficult cases where you do have these very high BMIs, which are precluding effective therapies and making the cancer more difficult to treat. And certainly under-treating cancer does have a higher risk of cancer recurrence and ineffective therapy. So it's something we do have to consider.
Well, actually, from now we can use the GLP-1, but 2-3 years ago we cannot use it as semaglutide for that.
No.
Yeah, that's why
we didn't have it.
Yeah.
Okay, I think we have no time to continue. So I would like to extend my sincere thanks to all the participants, all the panelists, and speakers for the insightful and thoughtful discussion on this important topic. Just as a reminder, the webinar has been recorded and will be available on the IFSO Virtual Academy, accessible through the IFSO website and YouTube channel. And the next IFSO webinar hosted by IFSO European chapter will be take place on May 22nd and will focus on metabolic and bariatric surgery as a therapeutic strategy for MASLD. Thank you all once again for your participation. Wishing everyone a wonderful week ahead. Thank you.
Thank you, everyone.
Thank you.
Bye.
Thank you very much.